before we gave them iron, IV iron, and some of the reactions to the IV iron now have been attributed to what we did to them with the pre-medication medicine. So they have changed the recommendations for that as well. So dose. So the goal is to treat the anemia or fully replace the iron stores. The calculations are somewhat involved. The calculation for each of these is different. It's based on weight, but it's also based on their other indices. The dosing calculations or formulas are published in the package insert for the product. They're also online. You can do that as well. So what I want you to know is that where they're available and that they are based on weight and their iron, their indices. Let's see. Depending on the total iron dose and the product, the iron can be replaced with one administration or spread out over several, usually 3 is about the most I've seen, given 3 to 8 days apart. So you can see that within a month you could, or in a couple of weeks, you could replace someone. Let's look at their adverse reactions, because those are the ones that are most worrisome. So in terms of their more allergic reaction, mild reactions are common. These would be itching, flushing, sensation of heat, slight chest tightness, blood pressure goes up, back and joint. Most patients are warned that they will have mild arthralgias, myalgias. They also will, if they have like arthritides or inflammatory arthritis, they usually will have a worsening of that for a few days following the injection. The moderate and severe reactions are usually symptoms of anaphylaxis. Those have to be handled like we would any other anaphylactic response. On the next page, non-allergic infusion reactions. These are self-limiting. They are not considered allergic. These are more, we don't treat them, we warn the patients, and we address them only if they're severe. Self-limiting urticaria, so it shows up, goes away. Palpitations, dizziness, fever, arthralgias, myalgias, neck and back spasm. Not fun. They can occur during the infusion, they can occur after the infusion is over, even for a few days. Risk of infection has been a worry. I told you that our bacteria require iron to grow, multiply. Viruses, all infectious agents require them. So it's been a worry that if we give people iron, that we will increase their risk of infection. That risk is considered to be negligible. However, if someone does have an active infection, it's recommended that you do not treat them during that active infection, and you wait until they are considered cured of that infection and then administer it. People are at greatest risk for an adverse event are those that have histories of allergies, asthma, inflammatory diseases that are listed there. And I told you about the inflammatory arthritides flaring. Those are usually handled with giving corticosteroids before and then for a few days after. And so you're treating it like you would a flare anyway of their arthritis. Questions about those? Okay. So response to iron supplementation. So this is kind of in the order that you start to see things. Their symptoms, their sense of well-being usually increases pretty quickly, like within a day or two. Their pagophagia goes down or away. And these will all change before you see much change in their red blood cell indices. The papillation of the tongue will improve, so I've given you the before, and I've given you a normal one tongue to compare to. So that will start to look more normal. If you look on page 13, lab response. So early on, now in mild disease you may not see this, but in more moderate to severe anemias you might see reticulocytes. So people call them reticking or ticking or all kinds of what do you call those? Abbreviations, verbal abbreviations would be a good. So what are reticulocytes? What kind of red blood cells? They're immature. So the bone marrow will just start pouring them out. You've given them now the material they needed. They didn't have enough iron to make red blood cells and even make really good ones. So now they're pouring it out. Okay? So that will, if you're going to look for that or wanting to look for that, it will occur very early on. Hemoglobin concentrations will rise in about 1 to 2 weeks. Now that, it's not as fast, that's with oral mostly. For iron, IV iron, it's a little bit slower. Hemoglobin should increase by 2 grams per deciliter over 3 weeks. So in the first month, you've got this response. The hemoglobin deficit should be corrected by about 50% 1 month with ongoing treatment. Normalization of hemoglobin levels shall occur in 6 to 8 weeks. What is a normal hemoglobin level?
12
to 15. Hair iron males. What's males? Those you ought to start nailing down because you're going to see them every time you turn around. So hemoglobin you ought to nail down. Do you have to? What's hematocrit? What's an easy way to remember hematocrit? It's 3 times the hemoglobin. Administer iron until levels of ferritin and transferrin saturations normalize. That tells you your stores are replenished. As long as you've treated the underlying cause, then they should be good. Monitoring oral therapy, you're going to check hemoglobin, reticulocyte count, maybe. If they're mild, you may skip that. Review the ability to tolerate the iron. So you're going to see them back. Are you taking it? How do you feel? Let's go get some blood. IV iron evaluated after 4 to 8 weeks. IV iron can interfere with some of the assays that you will use to evaluate, so we don't use it. We don't check those right away. So waiting 4 to 8 weeks, we'll get past that assay interference. What if they don't respond? Are you taking the drug? Okay, if it's IV, you know that they took it. Reduced absorption, what are you taking it with? Blood loss exceeds iron intake. You didn't have the right diagnosis. Maybe they've got a different type of anemia. Maybe they have thalassemia. Maybe they have other things going on with that hemoglobin. More than one diagnosis. Inflammatory state that blocks intestinal iron regulation. So more towards the like the ones we've already talked about, Crohn's, ulcerative colitis, others. Therapy that was effective, but the bleeding recurred. Okay, things to think about. Questions about that section? Okay, let's talk about kiddos. So they've done the very same thing with kids that they've done with adults. They've lowered the dose recommendation. The recommendation used to be 3 to 6 milligrams per kilogram, and now they recommend 3 milligrams per kilo of elemental iron. It comes in all kinds of dosage forms. So for kids, you've got drops, you've got elixirs. Elixirs usually have an alcohol base. Syrups are usually a sugar base. Okay, like you know already. Okay. And then the drops. So lots of different ways to get it down a kiddo. The other salts are available just like we saw in the forms that we use for adults. There is a polysaccharide iron complex. It comes also with folic acid and B12 in it. That is the one I was telling you about, has been shown not to be as effective as ferrous sulfate in terms of raising the hemoglobin. So you may want to avoid that one. There's others certainly you can use. So iron should be given 30 to 45 minutes before meals or in between meals. Only with juice or water, not food or milk, just like with the adults. Adverse effects, fairly uncommon if you're giving the dose once a day instead of multiple times a day. It makes it easier on the mom trying to figure out how to move it around all their eating habits for smaller kids or for infants that are feeding regularly or frequently. Liquid, so the one thing with the liquid preps is it will stain the teeth. It's not permanent. So if you'll brush their teeth or wash or rinse their mouths out after you give it, that usually does it. If they suck their fingers or their thumbs, they'll stain. It will come off, but it tends to stay around for a while. So all of those are reversible. So what do we do in kids? Well, if we look at mild versus moderate to severe. So mild, these would be kids that have hemoglobins of 9 or above. We're going to check a hemoglobin or a complete blood count about 4 weeks after we start therapy. And we're expecting that hemoglobin to go up by about a gram per deciliter. Children with moderate to severe would be those with hemoglobin less than 9. Then you can look for a reticulocyte count if that was needed, or check a hemoglobin, a CBC at least 1 to 2 weeks after starting therapy. You ought to have a sense of what do you monitor with, what are your indices, what's going to tell you if you're getting to your goal. Okay? So your goal in mind is going to be 2 things. What are your goals? Body stores, it's kind of your second. What's your first? You're going to get the anemia up. You're going to increase their hemoglobin. That's because you increase their ability to produce red blood cells. So with your goal drives your monitoring parameters. What tells you that you're getting to your goal? Okay? And then time frame. Okay? So if you'll think about it in that order, that should help. What am I wanting to accomplish? How am I going to know that I'm doing that? And how soon can I accomplish that?
Is it grams or milligrams?
Grams.
Okay, on moderate to severe it says 9
Okay, you know
milligrams.
that. Okay, you know that. It's grams.
Does the dosing vary from moderate to severe or mild to moderate?
Say what?
Does the dosing vary when you have a mild anemia or a moderate anemia?
From what I can tell, no. I would say probably mild to moderate, no. Severe, they don't call it out. So I think there it goes to how severe it is, how much is it affecting the person, and how fast are you wanting to get there. So if you've got to do it quickly, you can get a transfusion. Okay? Usually don't go to IV iron in kids. You can. We usually are going to do it orally. With children, a lot of times it's going to be preventative from nutritional deficiencies, and then other diseases may then cause those that are left. Yes.
Are kids doing daily or the Monday, Wednesday, Friday, once the adults?
Well, I'd say up to this point it's daily. So I'm not a peds trained person, so I don't know. Has anybody worked in a peds group? Sometimes we have people that. So we will hit this again when we get to the pediatric module. You'll see this another time. Let's see. And again, you're going to treat until all indices have normalized. And they recommended, at least in the pediatric material I read, recommended 1 month after that. Reasons for non-response, non-adherence, or you didn't incorrect dose. Don't have the right diagnosis. Ongoing blood loss or malabsorption. So with kids, you have to look at what kind of milk are they drinking. If it's cow's milk, unmodified cow's milk, you can get a colitis that then interferes with the absorption of the iron. Celiac disease, commonly diagnosed in kids. Other autoimmune diseases, kids have type 1. They tend to look, type 1 diabetes, they tend to look for celiac as well. Presence of inflammatory bowel disease, not very common in young children, but can be diagnosed in childhood, especially in adolescence. Iron therapy, again, I already said it's not as common to go to that as with adults, but iron formulations for children, the one that they use the most is the iron sucrose or the Benefir. Diet therapy, let's look a little bit at this. So so we don't recommend cow's milk in the first year. That protein, the milk protein is a is an immune stimulant. In fact, we think some of type 1 diabetes is tied to the ingestion of cow's milk before the age of 1. So cow's milk, looking for what parents are doing is important. So children in that first year, recommend breastfeeding is the recommended, or a iron fortified formula. So the recommendations I read said a cow's-based milk formula is okay if there is no evidence of the colitis. That children should not receive unmodified cow's milk in that first year. If you look at toddlers, then is the next, usually about six months is when they recommend that you start to introduce foods from breast milk, or I guess formula feeding. So you're introducing cereals. Those cereals are iron fortified, the ones that we start. And then they'll start vegetables and meats and then fruits. So then they'll start getting some iron through that. If a child is over 12, here's the recommendation is 20 ounces of milk or less a day. And that combines, if you're still giving a formula, that whole amount be 20 ounces or less. So start getting them off the formula. If you're going to use cow's milk, keep it to that limit. Higher intake of milk, increased risk of iron deficiency anemia. Okay, that's all I have to say about iron. Any questions or comments? Professor Rourke, any comments? Okay, let's move on to the last three, I think. So B12 deficiency anemia. So what anemia are we dealing with here? We're looking at B12 and folate. Macrocytic. Okay. Why are they macrocytic? Why do they get macrocytic? They what?
It's an issue with the nucleus and the cytoplasm.
They can't divide. Okay, so I put in here at the top, because I am a pharmacist and drugs are near and dear to my heart, the drugs that are B12 deficient. It's kind of out of order, but I didn't know if that had been discussed before. So these are the three more common. So proton pump inhibitors and H2 receptor antagonists. So think gastric acid reduction. Okay. So why would that affect B12?
It needs a certain acidity to be absorbed, right?
Needs acidity to extract the B12 out of the foods. Metformin, so metformin is a drug that is used for diabetes, very common, first-line drug. Long-term use with it is associated with a B12 deficiency. But I mean, you have to use it for several years. Those who are at higher risk or have low values when they're started on metformin may see it sooner. Nitrous oxide, what is that? What?
It's for your heart.
For your heart? No. It's an anesthetic, so it's an inhalant. It's also a recreational drug. Oh my gosh, poppers, hippie crack, whippets.
Oh, women.
Oh, yeah. I know eventually. It's nitrous oxide. You need to have Dr. Britton tell you what we worked in an ER pharmacy together, and at night when we were residents, and he dropped on accident an ampule of nitrous oxide. It was hysterical to watch him. Oh my gosh! You think he's funny and talks now? You should have seen him. If there were no iPhones at that point, I'm sure he would love to know you.
I'm gonna ask him what is it.
No, I don't know if he knows it. He might know. He'll know poppers if you say poppers. That's what we call them. Because you had to pop the ampule. Okay, prevention of vitamin B12 deficiency. So remember, we talked about this in nutrition. Vegan, strict vegetarians. No meat, no eggs, no cheese. So they are at the highest risk, and they need to be on supplement. Especially pregnant women who are following a vegetarian diet. Remember, we talked about that they can have a successful pregnancy. But B12 deficient moms give birth to B12 deficient babies, and if they breastfeed, the children become even more B12 deficient. So it's important in that, with those groups, to have B12 supplementation. Interesting, the Mediterranean diet, depending on how much meat they include in that diet, can also run deficiency. But it's variable, just depends on how they, how they do it. Remember I told you there wasn't any one set Mediterranean diet, so it will be depending on what they include in their diet. Gastric and bariatric surgery must be supplemented. You've taken out that absorptive capacity, you've decreased their acid production, and so they need replacement. I talked about that one. Disorders of small intestines. If you have a disease that's affecting the distal ileum, that's where that intrinsic factor B12 complex gets absorbed, then those folks could also be at risk. And then nitrous oxide exposure. And it can lead to a rapid B12. So if you have abusers, or they are exposed to nitrous oxide for a prolonged period of time in a short span of time, they are at risk for rapid onset. So they will develop those neurologic symptoms associated with B12 deficiency. Okay, so goals of treatment, we want to reverse the body stores, and the hematologic manifestations. Dietary. So you can see why. So you can see why vegetarians have trouble. The strict ones. Now, remember we talked about that there's. So we talked about the fact that some vegetarians include eggs and cheese and fish. Okay, so asking them about that's important. What's that vegetarian diet look like? Cereals are fortified. That's one way that vegetarians can get some B12. Milk and yogurt would be another. So the dairy, depending on their dairy intake. There's lots of products to replace. A lot of them are over the counter. For a long time we had only the parenteral, that's the red injectable up there. And they all vary depending on dose, and they will depend on how often for the dosage form. So let's kind of look at those. You've got liquids, tablets, lozenges, solutions, nasal. You've got a nasal spray and an oral tablet. The more you go oral, the higher the dose you have to give and the more adherent you have to give. The parenteral, we do once a month. Once we've got you loaded up, it's once a month. The nasal spray is once a week. The orals are all high dose, about probably 7 or 8 times well, even higher than that. They're about 1,000 to 2,000 micrograms a day, whereas the parenteral is 1,000 micrograms a month. Okay, so different. But people can be replaced orally in some circumstances. So if you look at the next page, pernicious anemia. If that's your diagnosis, then it's preferred that you do parenteral. You can't correct them with oral usually. So you're going to use parenteral, you're going to load them. I've given you the initial dose, so it's 1 milligram every day for 1 week. That saturates the stores. Usually their neurologic symptoms will respond very quickly. Follow-up dosing has been the milligram every week for 4 weeks, and then you can put them on monthly. Don't use oral. Bariatric, you can go lots of different ways. You could go oral, you can go nasal, you can go parenteral. Any of those. You don't have to know the dose on those. The nasal is just 1 nostril once a week. So just keeping that in mind. Oral B12. For your vegetarians, this is a good source, is to just do it orally. These are all over the counter, so you might ask people. People can probably will be self-treating themselves. It's 1,000 to 2,000 micrograms per day, every day. So adherence has to be good. I figure if they can stay on a vegetarian diet, they're probably going to be pretty good candidates for good adherence. Don't use the time release. They are not as good. Avoid them in this situation. Response to treatment. If you look there, I moved from what most rapidly resolves to what takes the longest to resolve. So look at what resolves first. Markers of hemolysis. So red blood cells being destroyed. Serum iron, indirect bilirubin, and LDH fall within 1 to 2 days. Bone marrow erythropoiesis. So it starts putting red blood cells back into the system within 3 or 4 days. So it has the tools, it can do it. The anemia resolves in 1 to 2 weeks, normalizes in 4 to 8. But again, just like we saw with iron, they may report feeling better before any of those indices change or move out. Hypokalemia is an important one to look at because when you are making a lot of new cells, so if this is a more severe anemia, they will use a lot of potassium and their potassium levels can fall. So if they're at risk, if there's a high risk for them in a hypokalemic state, then that is one to keep in mind. The neurologic abnormalities respond last, and they may not fully recover, but it takes up to a year to judge that. Okay? So you'll see return within the first 3 months. They'll continue improvement up to about a year, and then that's about the best you see. Questions about those? Okay, good. Let's go on to folic acid. So the term folate and folic acid really, in a purist sense, mean different things, but people use them interchangeably, and I am just as guilty. So this is really a folate deficiency, not a folic acid deficiency. Folic acid is synthetic folate. It is, so we make it and we add it. If you're going to fortify a cereal, we use folic acid. If you take over-the-counter folic acid, it's the synthetic. So that's, in a purist sense, that's what folic acid is. Folate is dietary B9. In folate, okay, folic acid, folate is B9. So folate is dietary. Okay, so our goal is, again, we want to get their red blood cells looking back to normal. We want to replace their stores. Now, this is a B12, this is a B vitamin. Most B vitamins are what? Water soluble, fat soluble. They're water soluble. Most of them don't have big stores. B12 does, and folate does too. So there are stores that we can replace, and we want to resolve any signs and symptoms. So what would be a sign of a folate deficiency?
Immunity?
Pardon?
I might be wrong. Is it immunity?
No. How would you know if someone had a folate deficiency?
We can look at it.
Well, you can look at the, you can measure it, but they have those big cells, so they have a megaloblastic anemia. Okay, so what is the danger of giving folate to someone who has a megaloblastic anemia and you don't know the cause? You're masking a B12, because B12, the difference between the two is what? What goes on with B12 that doesn't go on with folate? The neurologic. Okay. So you don't want to treat a megaloblastic anemia if you do not know the cause, because then the neuro changes can go ahead and continue. Okay. So folate, now they're complicated. It's a twin princess. So in our diet, it's in the form of polyglutamate. We have to convert it to a monoglutamate to get it absorbed. And then we convert it a couple of more times, and we get it to this tetrahydrofolate, and we methylate it, and that is the active form. Okay, so just know that there's multiple steps. This one shows you another where you've got conversion in the gut, and then it moves into the enterocyte. Those are busy little cells. And they methylate it eventually to that tetrahydrofolate form. That's what moves out, and that's what's active. And I think that's folic acid. Okay, foods high in folic acid. So if you're mostly eating junk food or processed food, you don't get a lot of folate. So we tend to not be we tend to have a folate deficiency. So you can see it in the diets of a lot of people. They don't eat fruits. See the vegetables there. You see the legumes are another good source. So all those good things we talked about in nutrition are good folic acid or folate. Okay. All right. Conditions that can produce a folate deficiency are mostly nutritional deficiencies. Could be in nursing home patients. Now they have more liberalized. If you go into a nursing home, they've got food everywhere. It is a diabetic provider's nightmare because they just put food everywhere and allow them to eat freely. So that was to overcome their restriction to foods. Alcoholism, children. Next page, page 20. So if they have impaired absorption, so again, the inflammatory bowel diseases, celiac, another inflammatory, intestinal short circuits, probably bariatric surgery, you're going to have these folate deficiencies. Medications, I want you to be aware of these, there's not very many. Phenytoin is probably the classic one that they get folate deficient. The other is methotrexate. Methotrexate is a folic acid antagonist. In fact, when we get to rheumatoid arthritis, we'll talk about methotrexate. We have to give a folate or folic acid supplements to those folks, or else they get into real bad trouble. Trimethoprim, where have you heard of it? It's an antibiotic. So Bactrim has trimethoprim in it. Usually we're not using it long enough to cause most people problems, but we are going to come into diseases where we use it chronically, and those folks are at risk of developing a deficiency there. And then alcoholics, based on their food intake or their dietary intake, could also become deficient. Increased requirements, pregnancy, big one. We're going to talk about it here, we'll talk about it again. It'll be very important to pay attention to that. Growth spurts, hemolytic anemias, neoplastic, you've got lots of cell turnover, chronic inflammatory diseases. The inability to use the folic acid. Again, drugs, loss is greater than what you are repairing, and then hemodialysis. Signs and symptoms are listed there for you. So lots of constitutional symptoms of fatigue, pallor, tachycardia, pale mucous membranes. Under that second bullet, that beefy red tongue, personality changes, lots of things can go along. Loss of skin elasticity, early graying of hair. We talked about the major differences. Lab test, MCV, what's MCV? Mean cell volume. Why would that be helpful?
It's the size.
Knowledge of the size. So in iron deficiency, what would you expect it to be? Small. Okay. So you can test do your folic acid test, do your retic count, hemoglobin, hematocrit, red blood cells. So the same indices that we use for the other anemias are going to be helpful here as well, except you need that folic acid level. Okay. Therapy. If you're going to use folic acid, a synthetic replacement, it comes in the monoglutamate form. So it comes in the most, a very absorbable form. So that's the absorbable form. The gut can take it from there and convert it into the active form, the tetrafolate. So doses. So to treat a megaloblastic or a macrocytic anemia, it's 1 milligram a day. If you've got somebody on phenytoin, you can use a replacement of about 500 micrograms a day to offset what the problem that the phenytoin causes with folic acid metabolism. All of these I want you to know. Pregnant and lactating women need about 800 micrograms a day. That is what a prenatal vitamin will have. The next one, very important, all women of childbearing years, so that's from 15 to 44, need to be on a folic acid supplement. They need to be taking 400 to 800, regardless of dietary intake, because lack of folic acid or folate in the diet can lead to an increased incidence of neural tube defects in an infant or in an embryo. So neural tube forms very early, it's about the first couple of weeks of an embryo's life. If you do not have enough folic acid at that point, or folate, then anomalies in that system can occur. So spina bifida would be a result of that. Anencephaly, no brain, would be a symptom of that. So that's to prevent 400 to 800, because women can become pregnant and not know they're pregnant for several weeks. They're already beyond that neural tube development. So that's a recommendation. So all those women you see, pediatrics and in family medicine, wherever, OB, internal medicine, need to be on it. Females at high risk, what if they've had a child with a neural tube defect before? Then we treat them with 4 milligrams a day. We usually start them a month before, and you want a planned conception. At least 1 month before they are attempting to conceive, and we continue at 3 months through. And they can do okay. There are, when we get to OB, we'll talk about this again, there are some drugs that increase, like carbamazepine greatly increases the risk for neural tube defects. If a woman has to be on that, then we would add that as well. That you don't have to know, I'm just giving you a preview of coming attractions. Okay, those you've got to know, they are so important. And public health is promoting that folic acid supplementation. Duration, so how long do you treat? 1 to 4 months. Now we're back into treatment of the anemias. We want to increase their dietary intake, help with that. Monitoring, you're seeing the same kind of pattern. They're going to feel pretty good as soon as you start treating them. Indices lag a little bit behind that. You're checking about the same time you would for the other replacements. And then you're going to go for about 4 months to get scores. Okay, questions? Okay. The last is, and again, I am just going to touch on these. Think of this as more of an introduction to these drugs. So anemia of chronic disease. We are always going to treat them with iron, and we're going to replace other things, folate or B12, if they are deficient. Because if we use these drugs and they are deficient in those other areas, they can't make the red blood cells. So we're always going to, in tandem, address any other deficiencies they have. So anemia of chronic disease is just what it says. If people have long-term diseases like kidney disease is a very commonplace, HIV, other autoimmune diseases, they can develop anemia along with that. They're now looking at the role that hepcidin plays in that, because these diseases tend to be associated with inflammation. And so we think that this is what's playing a big role, is that it goes up, and so the ability of the body to absorb iron goes down. So we have agents that are erythropoiesis stimulating agents. There's a couple of them on the market. How they work, or how erythropoietin, which is the hormone that we produce, is that anytime our oxygen levels get low, then the kidneys are going to respond as well as the liver, and they produce a hormone that directs the bone marrow to increase and put out more red blood cells. And that increases oxygen carrying capacity. When that more normalizes, it's a negative feedback, and that erythropoietin goes down. So these substances or these drugs mimic the effect of erythropoietin. They have the same action. There are two on the market, Epigen, Procrit, and Erythropoiesis. They both have the same mechanism of action. I'm blanking on how to say that generic name. Darbepoetin. Sorry. Longer half-life, administered less often, more expensive. Look on the next page. So their mechanism of action, same as erythropoietin. Initial dose. Here's what I want you to know. They're based on weight, and they're given IV or sub-Q, and they're usually given anywhere from 3 times a week to once a month. It depends on how the patient is responding and what kind of adverse effects they're having. All is kind of combined. What I have given you is based on what they do in chronic kidney disease. It will be different for different diseases, and kids will be even more different. Again, they're most effective when iron, cobalamin, B12, and folic acid are normal. What I want you to know is under monitoring. It's very important. So we don't give them enough to correct them back to the normal range. We correct back to 12 grams per deciliter of hemoglobin. The reason for that is beyond that, the risk of cardiovascular events, fatal cardiovascular events, goes up. So the recommendation is to go only to 12, and you'll see the other is that we do not want it to increase more than 1 gram every 2 weeks. So those are your big monitoring parameters. So the big things to know here is, what are these agents, when are they used, and that they are, their mechanism of action, and that monitoring. Very important. Okay, thank you very much, and I have a good, great spring break, and I will see you afterwards. Thank you.
Are you gonna get somewhere? Sorry. You're okay. Oh my goodness. I see a butterfly with my goodness. Are you gonna go up there? What? Are you gonna go over there? Y'all go. No, eating in the half. Or over there. I have food, but I'm gonna turn it on. I didn't want to. You need to do that tonight. Yeah, I thought it was a Friday. It might be. I don't know. I'm gonna do that either way. Yeah, I just did it. I just haven't sat down and done it. That's what I knew I wouldn't be able to, so that's why I was like, okay, I'm gonna come to at least one a night. Yeah, but they only eat 3 minutes. Like, I didn't know.
Where do you do? I see you have your lunchbox.
I do have my lunchbox.
Would you like to go to your plate?
No.
No.
Yeah, I mean, it's not quite the problem.
I understand. That's why I wasn't. But is there anywhere?